Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast. For a long time, the treatment pathway for locally advanced rectal cancer seemed pretty fixed. A combination of treatments to shrink the tumor, followed by major, often life-altering surgery.
A very established pathway. That surgery, total mesorectal excision, or TME, can have profound long-term consequences for patients. So for years, a powerful question has been driving research. What if some patients could safely avoid that surgery altogether?
Right. And avoiding surgery puts immense pressure on imaging to give a clear, confident answer to the question, is the cancer gone? Or at least gone enough to just watch it.
Precisely. It fundamentally changes the job of MRI in this disease, and that's the focus of a review paper published in the July 2026 issue of the Korean Journal of Radiology, titled Magnetic Resonance Imaging After Total Neoadjuvant Therapy in Rectal Cancer, Treatment-Oriented Response Assessment and Reporting for Watch and Wait Management.
Total neoadjuvant therapy, or TNT, let's start there. What is it, and why is it such a big deal in this context?
At a high level, TNT reorganizes the treatment schedule. Instead of giving some chemotherapy and radiation before surgery and more chemo after, TNT gives all the systemic chemotherapy and radiotherapy before any surgical decision is made.
The paper says this lowers toxicity and improves patient completion rates. How so?
By moving the systemic chemo up front, you're treating the patient when they are strongest, before they've undergone major surgery. Post-surgical recovery can be tough, and many patients struggle to complete adjuvant chemotherapy. TNT gets that treatment in first, which also seems to lead to better control of distant disease.
Okay, so it's a more effective and tolerable regimen, and the main result of hitting the cancer harder up front is what?
You get significantly higher rates of what's called pathologic complete response, or PCR. That means when you look at the tissue under a microscope after treatment, there's no viable cancer left.
Which is the biological green light for considering non-operative management, the watch and wait approach.
You nailed it. And this has fundamentally elevated the role of restaging MRI. It's no longer just a roadmap for the surgeon. It's becoming a primary tool for deciding if surgery is needed at all.
So MRI is moving from a supporting role to a starring one. The paper contrasts this with the old way, right?
It does. With conventional chemoradiotherapy, MRI was used to assess things like mesorectal fascia involvement to help plan the surgery. But for the most part, nearly everyone proceeded to TME unless they developed distant metastases during treatment.
So the scan informed how to operate, not whether to operate. Even in the earlier TNT trial, if this was the case?
That's right. The paper points to the Rapido and Prodige 23 trials. Even with TNT, all patients in those studies went to surgery regardless of their response. So even if the MRI looked perfect, showing a complete response, the protocol was still surgery. MRI's role remained limited.
When did that start to change?
The authors argued the paradigm shift really crystallized with trials like Oprah. This is where the MRI results started to directly dictate the patient's path.
What did the Oprah trial do differently?
The Oprah trial used MRI, along with endoscopy and digital rectal exam, to sort patients into 3 groups based on their response to TNT.
Okay, what were the groups?
They were categorized as clinical complete response, CCR, near complete response, NCR, or incomplete response, ICR.
And what happened to those groups? This is the crucial part.
Patients with an incomplete response went to surgery, as expected. But, and this is the key, those with a complete or even a near-complete response were offered a non-operative watch-and-wait approach.
Hold on, even near complete? That sounds like a major change in philosophy. You're actively deciding to monitor patients who have some form of residual signal on their scan?
That's the conceptual leap. The trial allowed for observation of these NCR patients, and it showed that many can be safely managed. Some even evolved to a complete response over time with no further treatment. It also highlighted MRI's role in ongoing surveillance to confirm sustained remission or detect regrowth early.
Let's get into the specifics then. How were these categories defined on MRI? The paper has Table 1 outlining the criteria.
Let's break it down. For a clinical complete response, or CCR, the T2 weighted image should show a normal appearing rectal wall or only dark signal, which represents fibrosis or scarring.
And on diffusion-weighted imaging, or DWI?
No visible signal on the high B-value images. Basically, no restricted diffusion to suggest a viable tumor cells. And for lymph nodes, either none are visible or there are just a few small ones, less than 5 millimeters.
Okay, that sounds straightforward. What about the other end, incomplete response?
For ICR, the T2 image shows more intermediate signal than dark fibrotic signal. On DWI, there's insignificant regression of the high signal compared to baseline, and the lymph nodes are persistently enlarged.
And the middle ground, this near-complete response category?
This is where the nuance is. On T2, NCR was defined as mostly fibrosis with 1 or 2 punctate foci of intermediate signal, just a couple of specks.
What about DWI for NCR?
Significant regression of signal on high B-value images compared to baseline. It's not gone, but it's much, much better. For lymph nodes, it's partial regression, but they're still 5 millimeters or larger.
The table also mentions a tiebreaker rule. What if the T2 findings suggest NCR, but the DWI findings look more like ICR?
Great catch. The rule was to assign the patient to the lowest or worst response category. So in your example, the patient would be classified as having an incomplete response and would proceed to surgery. It's a conservative failsafe.
It seems this all points to a broader shift in the diagnostic threshold radiologists are using, something the paper talks about directly.
It's a central theme. Historically, the approach was to maximize specificity. The goal was to avoid, at all costs, misclassifying a patient with residual tumor as a complete responder.
A low false positive rate. You'd rather 10 patients get unnecessary surgery than 1 patient miss necessary surgery.
That was the implicit philosophy, but the paper argues the threshold is shifting toward higher sensitivity.
Meaning we're more willing to accept a slightly higher risk of calling something a complete response when it isn't, in exchange for sparing more patients from surgery.
Exactly. And a few things are driving that. First, as we said, TNT works so well. The PCR rates are roughly double those of conventional therapy. The paper quotes rates around 28% versus 14%. When the baseline rate of true complete response is that much higher, radiologists can be more confident in calling it.
The pretest probability is higher, so the post-test probability of a positive read is more reliable.
You got it. And second, the growing evidence from trials like OPRA shows that even patients with just NCR can be safely monitored. The safety net of close surveillance is strong. If there's local regrowth, it's typically caught early and can be successfully treated with surgery then.
So the consequences of being wrong are less dire than once thought. The paper also brings up another layer of complexity, tailoring the MRI read to the specific treatment.
This is a subtle but important point. Think about a patient in the PROSPECT trial who might receive chemotherapy alone without any radiation.
How does that change the MRI interpretation?
Well, post-radiation changes can really muddy the waters. Radiation can cause inflammation, edema, and dense fibrosis, all of which can have intermediate T2 signal and sometimes even restrict diffusion. They can mimic residual tumor.
So a scan without those radiation effects is, in theory, a cleaner picture, easier to interpret?
That's the idea. The authors cite a study suggesting MRI performance for predicting PCR was indeed higher in patients who received chemo alone. It's a better signal-to-noise problem.
And what about newer treatments, like immunotherapy?
That adds a whole new challenge. Immunotherapy can cause a phenomenon called pseudoprogression,
Where the tumor looks like it's growing on the scan, but it's actually an inflammatory response to the treatment killing the cancer cells. Yikes! That's a massive interpretation challenge.
It's a true dilemma. The tumor gets bigger, but it might be good news. The paper is frank that for rectal cancer, where immunotherapy is still relatively new, the imaging correlates are not well established. It's an active area of investigation.
Let's circle back to this idea of near-complete response. It feels like the category with the most ambiguity. The paper says the definition is poorly standardized.
It is. The OPRA trial provides one definition, but it varies across the literature.
This is a major focus for future work. If the criteria are fuzzy, it's hard to conduct multi-center trials or apply these principles consistently in clinical practice.
So what's the current thinking? If it's not standardized, how should radiologists approach it?
The emerging expert consensus is to frame NCR as a temporary classification. Think of it as a holding pattern, a very good but not quite perfect response at the initial assessment.
A designation that says, this looks promising, but we need to watch it closely because it might evolve into a complete response.
Precisely. The idea is that this label is only applicable for the first 6 months or so after treatment. Beyond that, the response should have stabilized, and it should be definitively classified as either a complete response or an incomplete response. The near-complete label effectively expires.
Okay, that helps clarify. But MRI isn't done in a vacuum. How does it get integrated with endoscopy?
This is where it gets very practical and very tricky. Discrepancies are common. The MRI might show only perfect dark fibrosis, but the endoscopist sees a small ulcer or nodule.
Or the reverse, the endoscopy is clear, but MRI shows a suspicious focus of intermediate signal in the rectal wall.
Exactly. The paper notes there's no clear consensus on how to resolve these disagreements. A recent guideline suggested placing greater emphasis on the endoscopic findings, but the authors here add a note of caution.
What's their take?
They highlight data from the OPRA trial. Among 116 patients who had a CCR on MRI, 12 were still advised to have surgery based on what the endoscopist saw. Of those 12, 3 were found to have a true pathologic complete response at surgery.
So that cuts both ways. 3/4 of those patients did not have PCR, so endoscopy was catching real residual disease most of the time. But 3 did have PCR, meaning some surgery may still have been avoidable.
It shows that neither modality is infallible. The authors argue for MRI's indispensable role because it sees what endoscopy cannot: the full thickness of the rectal wall, the mesorectum, lymph nodes, and tumor deposits. They even cite a study where MRI detected tumor regrowth earlier than endoscopy.
Which brings us to timing. The surveillance schedule mentioned in the guidelines is intense. MRI every 3 to 4 months for the first 2 years.
It is. After that, it's every 6 months for the next 3 years. It's front-loaded because the data shows that the vast majority of local regrowths, if they're going to happen, occur within those first 2 years.
And the timing of restaging after TNT is still a major open issue, right?
Exactly. The paper notes that response assessment is often done 24 to 38 weeks after treatment begins, depending on the regimen. But trial protocols vary and better consensus is still needed. The reason is that tumor response evolves over time. Some near-complete responses at initial restaging can later become complete responses with continued observation.
Okay, so let's land this plane. What are the core messages for someone reading these scans?
I'd say there are 3 big takeaways. First, TNT has pushed MRI into a new, more central role. It's no longer just for surgical planning, it's a primary determinant for organ preservation.
It's a gatekeeper for watch and wait. What's number 2?
Second, this new role demands a shift in diagnostic thinking. The field has to move from a rigid, high-specificity model to a more sensitive and nuanced approach that embraces the category of near-complete response as a pathway to organ preservation under the condition of very close surveillance.
A new risk-benefit calculation, essentially. And the third point?
The third message is that this is still a work in progress. The field urgently needs to standardize the imaging criteria for NCR, determine the optimal timing and frequency of scans, and establish clear evidence-based protocols for how to integrate MRI findings with endoscopy and clinical exam.
So the role of MRI in rectal cancer is more critical and complex than ever, but the rules for this new game are still being written.
That's a perfect summary. It's a paradigm shift happening in real time, and restaging MRI is right at the heart of it.
A very clear overview of the rapidly changing landscape in cancer care. That concludes this episode of SummaryCast.